Good morning, everybody. Welcome to this morning's mental health session. My name is Shabina Welji, and it is my pleasure to be co-chairing this with my esteemed colleague, Dr. David Macklin. I think we're going to jump right into this because we are on kind of a tight schedule. This morning we have 4 speakers, starting off with a patient perspective. The format is going to be that our speaker will present their talk, and then there will be a couple of minutes for questions and answer after their talk. So I ask you to reserve your questions for after they've completed their talk. Just a couple of small announcements about what's happening later today. There is an Obesity Canada SNP networking session from 4:30 to 5:30 in this room to be held, to be directly followed by walking groups at 5:30 and at 5:45 to the Nature Museum. The group will stay at the Nature Museum until about 8 o'clock and then head to the Lieutenant's Pump Pub for dinner. Did you hear that? Lieutenant's Pump Pub. Anyway, okay, let's move on. Okay, so for our first speaker, it's my pleasure to welcome Ian Patton. He is a passionate patient advocate, and he works as the Director of Advocacy and Public Engagement of Obesity Canada. In this role, Ian combines his academic background and training with his personal lived experience with obesity to help reach individuals living with obesity across Canada and to realize Obesity Canada's mission of improving the lives of Canadians living with obesity. Ian obtained a PhD from Western University in kinesiology and completed a postdoctoral fellowship at the University of Toronto. So with that, please join me in welcoming Dr. Patton.
Hi, everyone. I first want to thank everyone for coming here and coming to the summit. I guess I'm double miking it here because I got one on my lapel, so I'll step back. Summit time is always a really interesting time for me. I always get really excited and motivated when I come to the summit and see all you people here. Obesity Canada has become a bit of a family to me. I've been involved with Obesity Canada since about 2007 as a student and a trainee. And there's a lot of familiar faces, but I always really get excited because with the networking and conversations that we have, there's always new people that are getting added to that family. So really appreciate you guys being here. And I always appreciate the space that we're given as patient advocates to kind of tell our truths and our stories and what we've experienced, because I think it really sets the tone for the rest of the talks and how things are going. I don't think that I can make you understand what it is that we've gone through or what I've experienced or what some of my peers have experienced, and I don't expect you guys to understand. But what I do really appreciate is that people consider us a little bit more now. They consider us in their work and what they're doing in their home lives, and they take that into consideration. I don't think that we're being overlooked like we were before, so I do really appreciate this opportunity to do that. So with Obesity Canada, I now have two kind of roles that I am involved in. The first is the public engagement side of things. So with that, my role is to help elevate the voice of individuals living with obesity in Obesity Canada and beyond that. So making people feel comfortable and safe and understand that their voice matters and their experience matters, and I think that's something that I'm really excited about. And we have lots of patient advocates here, and you're going to hear them throughout the week. I would encourage you to take an opportunity to meet them and talk to them a little bit outside of them standing up on the stage. They're really great people, and they do a lot of great things. The other part of my role is this advocacy side, and this is becoming it's a little bit of a new thing for us. But we're working to advocate for access to care and for the reduction of weight bias and discrimination. And so we're starting to push forward with talking to policymakers and talking to people and challenging those instances of weight bias and discrimination. And so you've probably already heard about the report card that was released earlier this week. I have a special ask. You've probably already heard this as well, but I'm going to hammer it home again. On the report card webpage, we have embedded a tool that will allow you guys to, with a couple clicks and putting in your postal code, add your voice to our advocacy efforts. So you put in your postal code, you make a couple clicks, and then there's going to be a letter that's going to get sent to your specific elected officials. And so this helps us with our advocacy. You might not think that your little letter or your click there is going to have an impact, but it does. So what it does for us at Obesity Canada is you are going to send your letter, and that policymaker is going to get 150, 200 letters. They might not read them all, but that's not the point. They're going to have all these emails in their email box, and they're going to realize that this is an important issue for the people that are voting for them. And then the following week, when I come back with an official ask from Obesity Canada to sit down and talk, we've got something that we can talk about. I can help you with this issue that the people in your constituency have deemed an important issue. We can talk about how we can work together. So please take a couple minutes, make those clicks, and help us with that advocacy effort. Okay, so I'm running out of time already. So I guess what I'm going to do today is kind of give you a quick overview of my experience, my lived experience with living with obesity. And I guess it really did start early on for me. I was one of those kids who grew up as the big kid. I knew fairly early on that I was defective and different. So it was about grade 2 when I started getting bullied because I was bigger. And you can imagine that's a really powerful thing to understand that your body's different and there's something wrong with you. And kids can be pretty ruthless early on. They know who's different, and they can hit that red button pretty effectively. That's a common thread that I have with a lot of my peers. They've all experienced bullying, and it's something that's pretty common. I think what was different for me was I was given some different tools to cope with it. And so for me, my dad stood up for me pretty early on. And when the school wasn't going to help me with the physical abuse that I was dealing with in grade 2, my dad essentially took me into the principal's office and said, if you're not going to do anything about it, Ian's going to handle it himself, and don't be surprised. Bully was dealt with. And I had some new coping skills. I had some friends. The first bully actually became probably my best friend in elementary school. But I had social skills, and I had the ability to cope with some of those challenges. And it's not something that I've heard from too many of my peers who've gone through that. So I kind of thank my dad for giving me some of that strength and resiliency. The other thing that I was given that really helped me was my ability to seek out activities that I excelled at, where my body was actually a benefit. So I played a lot of high-level sports: hockey, wrestling, football, rugby, all sports where being big is a good thing. And so my weight was actually encouraged, and that allowed me to actually, at times, ignore the fact that I was a lot bigger than everyone else and that I had an issue with my weight. So it wasn't until I got into my university years that I really, really recognized that I needed to do something about my weight issues. But university was a very interesting time for me, because it's when I got really, I started wrestling at a really high level when I got into university. And so wrestling's a combative sport where you got to make weight. You got to hit a certain weight category. And like any competitive sport, you're trying to find an advantage. So the idea being, you weigh in on Friday night for a wrestling tournament that happens Saturday. So you got some wiggle room there. And you can get a competitive advantage by being bigger than everyone else in the weight category when you wrestle. So for me, that was 286 pounds was the category I had to hit. So on a regular basis, I was walking around 300 plus pounds. Monday morning, I wake up and I'd start my weight cut for Friday afternoon. I'd make my weight. We'd go on a team binge to Eastside Mario's. And by the time I wrestled on Saturday morning, I was back well up over 300 pounds. So it was a weekly thing of going up and down and up and down. And I can imagine that probably did something to my system and how my body reacts with weight. And I probably don't have time to get into it, but there's some pretty significant things that we did to cut that weight. And if you want to hear about it, I can tell you later. It's not good. So I ended up getting a back injury. So by the time I started my master's degree, I stopped wrestling. So instead of being active 2.5, 3 hours a day, I wasn't doing that, but my consumption stayed the same, and stress went up through the roof, and my weight skyrocketed. It was another interesting point here through my graduate work, because here I was going through kinesiology, involved in Obesity Canada. I'm coming to conferences like this and talking about my research and talking about obesity and physical activity. And there was a real disconnect between my personal experience and my professional life. I felt like a fraud. Like, why would anyone listen to me? I want to hear about obesity and my thoughts on obesity, because here I am standing in front of you, this giant bloated man who clearly can't fix himself and isn't capable of doing this. So I had this big mental battle going on between what I was doing. It was like a self-imposed hell that I was kind of putting myself through every day. And it was actually Dr. Sharma who really made a life-changing moment for me at a conference like this. We were sitting down having a beer, and I made a comment about that. Why would I do this to myself? I just stand up there, and who wants to listen to me? Who wants to hear about obesity from me? And he very simply said, who else? Who else should talk about obesity? Then he got up and walked away and left me to contemplate my life decisions. And, but it was really effective. He's right. It was one of those things that validated me, and my experience and what I was going through was real and it was worthwhile. So that really helped, and that opened up the door for me to be a little bit more open and start reflecting back on some of the things that I experienced going through this weight gain and weight loss. The trigger point for me was the birth of my son. And when he was born, I kind of had that aha moment of, I got to fix this. I didn't want my son to remember the fat dad. I wanted him to remember me as a super skinny, fun, active, outgoing dad. And at that point, I wasn't that person that I wanted to be, and I didn't want him to know me that way. So I ended up having to get help. I was waking up in the morning really sick. I had hypertension, severe sleep apnea, and I got to the point where it felt like the fat was sucking the life out of me. So I went to my doctor and I said, I need help. And he gave me the usual runaround of, okay, well, let's go on a diet. Let's try some walking every day. And I had to stand up for myself and fight him a little bit on this one, because I'm a kinesiologist. I'm a certified exercise physiologist. I get the exercise piece of it. I get that. I've taught nutrition at a college. I get that piece of it as well. Something else is going on here and I need help. And I'm telling you that I'm not sure I'm going to wake up tomorrow morning. So what you're doing is not an evidence-based practice. It's not something that the evidence supports, and I need more help. And when I challenged him on that, I quickly got my referral to a bariatrics program. And I ended up having gastric bypass surgery in 2014. Surgery was an interesting thing. So right off the bat, I lost a whole bunch of weight. I felt a lot healthier. I was more active. Everything that I thought was my problem was going to go away. I wasn't going to be cured, right? I knew the science behind it. I knew that obesity was something that I was going to be dealing with for a long time. But all my problems that were related with my weight were going to be gone. And it's not necessarily the case, because there's more problems that pop up after the fact. There's problems of fitting into a world that you never fit into before. People giving you attention that you never had before. And how do you reconcile that? Right? It's a real big mental mess. People giving you attention and thinking, the first time that stuff starts happening, you get really excited. You're like, this is awesome. This is what I've been missing out on. But then it makes you sad and go, wow, we suck. Humans suck. And so there's that challenge there. And I think one of the biggest things is the fear of regain. We already feel like failures. I had to go and get help to deal with this issue. I felt like I was a failure. And there's an inevitable regain that's going to happen, and a lot of us do deal with a certain degree of regain. And so after we've gone through this honeymoon phase of I am invincible and I fixed everything and this world is fantastic, then things start tipping back up a little bit, and there's a huge fear of that regain, and that causes more problems. And I think it's almost like a self-fulfilling prophecy, because it actually triggers more regain, right? The stress and the fear of that actually paralyzes you to the point where it's going to make it worse. And those are some of the things that aren't considered when we go through this process of, losing and gaining weight and how we operate in this world is there's a lot of those other layers that kind of get peeled back when we lose the weight. So the idea that the surgery or the weight loss isn't going to fix all those problems it might actually uncover a couple more problems that we have to consider. So this process of being able to talk about it and understand and listen to other people and share their experiences, for me, has actually been a little bit therapeutic, because it makes me realize that I'm not alone. I have a lot of commonalities with other people. And there's other things that I hadn't thought about that maybe I should have considered earlier on, or I should have thought about. And it allows me to kind of be a little bit more comfortable in my skin. So I thank my peers for sharing their experiences with me and teaching me those things. And I really do appreciate the opportunity to kind of share some thoughts with you guys, and hope you guys have a really good day and the rest of the conference.
If there is one or two questions, we have some time for Ian. There's microphones at either end of the room. Otherwise, I would have a question. You can go ahead. My question to you, Ian, is in all your advocacy and really on the street out there, I'm wondering if you could share what you find is, what is the information, what is the communication that most kind of turns people? If you see someone start to consider in front of you obesity as a real medical condition because of something you've said, what is most effective in communicating that shift, do you find?
That's a good question. I think we have like this perception in society that it's not a medical condition, right? Like, and we've talked about that a lot, and it's a challenge to overcome that on a population level. But I find if I can get in front of someone, if I can talk to one person, that's an easy thing to do, because if I can tell them what I went through and they're like, yeah, someone I know went through something similar, right? It makes them kind of consider that. But on a big scale, without that personal connection or that lived experience, that idea that they can something they can connect to, it really makes it easy to brush it off and say, yeah, it's not that important, or it's not a medical issue or something like that. But when I get in front of people, that discussion's a lot easier, and I feel like I can make that shift by using that personal side of things.
Hi, thanks so much. I'm Andrea. I'm a dietitian with the bariatric surgery program in Newfoundland, in St. John's. We're a very small program. It's only myself and the nurse practitioner. We don't have access to psychology or any other support. But we do certainly, hear a lot and try and prepare our patients as best we can for those psychological challenges that you run into after weight loss. But we're very underskilled at that. And I'm just wondering, because you bring up a lot of great points that we try and bring up to our patients, but I'm wondering if you have anything that we can direct our patients to, either through you or any of your colleagues, that we might be able to direct them to say, look, this is some great information about the stuff you might run into after your surgery.
Yeah. I think those are some of the, what we would like to do with the Public Engagement Committee and Obesity Canada is create more patient-centered tools, and these are things that we have in the works, and so we'd like to have, we will have these things very shortly, things that can be downloaded, or infographics and things like that patients can use. I think the other side of things, and for me that's been really good, is the peer support. So connecting with other people who are going through similar things. But I think there needs to be a little bit of caution there, because some of those, especially the Facebook private groups and stuff, they can
that's all we have.
be a bit toxic at times, and they can share some really bad information. But if people are being open and honest and they're sharing their experiences, knowing that other people are going through it and how they experienced it will definitely help them.
Excellent.
Yeah.
Thank you.
Thank you.
Yeah, thanks.
It's really powerful. It's interesting. I don't know if you all heard Ian brings these words: defected, different, something wrong, can't fix myself, failure. What really stands out, I think, from that story is your self-advocacy, and it makes me feel bad for those who don't stand up to the bullies, right? Because there were two bully stories there, right? There was the school bully, and then there was the physician, right, who also, and then you stood up for yourself, right? And then you said, I actually need help. So it makes me really wonder if we can help those who don't have the same strong skills. Thank you very much, Ian, for sharing. Our next speaker is Dr. Valerie Taylor. She's going to talk about an overview of binge eating. She is a professor and chair at the Department of Psychiatry at the University of Calgary. This vacuum that takes people out west from Toronto struck her at some point. Sad to lose her, but her academic focus is on obesity, metabolic syndrome, and mental health. Please join me in welcoming Dr. Taylor.
I'm originally from Newfoundland, so it's very windy in Newfoundland. It's just blowing me. I'm going to land in Vancouver eventually. So thank you very much, Ian. I think we all have imposter syndrome, and every time I have to speak following you, I sort of feel like, what am I doing? Ian has such credibility and is such a powerful advocate, so continue to do what you're doing. Where is there a timer?
On the table.
There we go. Okay. I'm going to attempt to give you a very brief overview in the course of the next 15 minutes on a very interesting and controversial diagnosis outside of the field of obesity, and perhaps even more so to be trumped only perhaps by the words food addiction if we talk about sort of controversy around mental health and obesity. And that is the concept of binge eating disorder. And so just to give you some background, I've been with Obesity Canada probably since its inception, and when I started, binge eating disorder didn't exist. It wasn't an illness. And so it really only became recognized as an illness officially in about 2013. And so and I remember being here at one of the Canadian Obesity Network then conferences and doing interviews, and people talked about the fact that the newspapers wanted to talk about the fact that this was a made-up illness that was created by the drug companies in order to have one more thing to sell medications for. And I think there's still some of that stigma and real kind of misunderstanding about, is this an illness or is this kind of some sort of fake kind of construct? And certainly for myself in my treatment of patients whom have this illness, I absolutely know that this is a genuine illness that some people struggle with, and that contributes for some with their challenges with getting their obesity under control in a way in which they and their primary care physicians would like. So very briefly, in terms of diagnosing binge eating disorder, the main thing, and again, this gets a bit interesting after bariatric surgery, we'll talk about that briefly, and I'll talk about it more later this afternoon at a different symposium. But essentially, it's eating in a discrete period of time, and usually within a 2-hour period, an amount of food that's larger than most people would eat in a similar amount of time under similar circumstances. And so again, this doesn't mean Thanksgiving or Christmas and different religious holidays, regardless of which religious group you have. All religious groups have food as a big part of their celebrations. This is not what we're talking about when you talk about binge eating disorder. Those are usually times of celebration, and people eat together with friends and families. Binge eating disorder is the binges are rarely associated, for the most part, with sort of pleasurable eating, actually. People feel very out of control. They have a lot of regret during the eating, after the eating. It's often not kind of fabulous food. Binges usually, on average, are around 4,000 calories. That's a binge. That is on top of the normal kind of food that people would eat for their meals during the day. So that's a significant amount of food. Often has no real pattern in terms of eating, in that it's not, it can be leftover pizza, and then it's ice cream, and it's a box of cereal, and then it's back to leftover steak. It doesn't necessarily, it's not pleasurable. It's not, really eating for enjoyment of food. It's often done in secret because people feel quite ashamed of what they're doing, and It really is, it can be associated with a lot of negative emotions. Again, then they're usually associated, as we talked about, eating much more rapidly than normal, eating until feeling uncomfortably full, large amounts of food, feeling embarrassed by how much one is eating, feeling disgusted with oneself, depressed or guilty afterwards. And then there has to be a lot of distress, and then once a week for 3 months is usually the frequency. And these things do kind of come and go for individuals, and that they will have, just like any other kind of mental health illness or other chronic illness, is cyclic. It kind of comes, it stops for a while, it comes back. And that's one of the ways in which we often kind of talk about severity as a number of issues of binge eating disorder that a person is experiencing during a week. And it can become, again, binge eating disorder is not contraindication to bariatric surgery at all, but some of the literature will talk about sort of trying to understand the severity. And if somebody has, probably in the severe to extreme range, so binge eating kind of more than 8 times a week, that's probably at minimum something that should be addressed prior to bariatric surgery. And again, just to decrease the frequency of the binges because it will become problematic. In terms of understanding the differences between binge eating disorder and eating disorders, and so how does it differ from anorexia and bulimia? Anorexia, clearly it's energy restriction, there's an intense fear of weight gain, a disturbance in self, so often anorexics don't view themselves accurately in terms of how they physically look. And there is restricting behavior or purging behavior. So quite different than binge eating disorder. Bulimia is similar to the binge eating disorder in that you have the excessive consumption of food, but bulimia is then associated with some sort of restriction in terms of vomiting, purging, laxatives, reducing calorie intake at certain times. Quite interestingly, if we're thinking about bariatric surgery patients, we had a case in which someone would manipulate their gastric band as a form of kind of purging with bulimia. And so that was how they had bulimia, that they would use their gastric band to tighten and loosen. So lots of ways in which this can manifest itself. I think in terms of binge eating disorder and the illness of obesity, so I think one of the things that's a myth is that individuals who have the illness of obesity also have binge eating disorder or vice versa, and absolutely not. And it's not even most people whom are experiencing the illness of obesity have binge eating disorder. They don't. And certainly when you screen individuals in a bariatric surgery program, you would expect to actually see higher rates of psychopathology. Most individuals do not. And so I think that is important to understand, and it's also important if you're in the healthcare field that a number of individuals whom have a BMI less than 30 can be experiencing binge eating disorder, and it's something you have to be mindful for. In terms of just prevalence, again, something to be mindful of. Binge eating disorder is more common than anorexia and bulimia combined. So it is a significantly common illness. It's missed a lot. Certainly in terms, and it looks quite different in terms of clinical course, and so it frequently presents in a younger adulthood, so mean years in terms of episode is, so these episodes of binge eating disorder can be quite long. So 4 years, more common, like all eating disorders, more common in females than in males. Again, you can see a slightly older onset than we see in terms of right now, in terms of the data we have, than presentation of other eating disorders. And so 21 sort of peak years when you're just moved away from home, you're living on your own, you're trying to understand kind of how to cook and eat on your own, you're in a university residence. You can see all of these things can create problems for individuals who are predisposed to this illness. And you can see again, in terms of just kind of BMI, again, not the best way to categorize, but it's a crude metric, but just to get a sense of this is not an illness that you start to screen for only in individuals whom are seeking help with the treatment of obesity. This can occur beforehand, and it's important that we're aware of it and that we recognize this in our patients. Often very comorbid as well, and by that I don't think I've ever treated a patient whom just has binge eating disorder. Usually individuals will have symptoms of depression, anxiety, and interestingly, another impulse control disorder. And so there's a lot of comorbidity with attention deficit disorder. And some people will say that it's just a variant. The binge eating disorder is just a variant of attention deficit disorder, and they're all on the spectrum. Or substance use disorder. Again, speaking to kind of issues with impulsivity. There's some interesting talks at a session I chaired yesterday around kind of eating pathology and attachment style, and binge eating disorder being associated with sort of more of an anxious attachment style, and again, leading itself to this predisposition towards impulsivity. Really interesting, and I think this was a work that allowed people to actually understand that binge eating disorder is not a made-up construct. And certainly, like many psychiatric diagnoses, we don't understand the exact cause of binge eating disorder, but there's certainly a number of biological and psychological risk factors. Certainly in terms of some of our biology, we know that there's some reward center and impulsivity dysregulation associated with binge eating disorder. And so what we know is that individuals who have binge eating disorder, when you sort of start to look at them doing kind of scanning work and such, reduced activity in terms of impulse control regions of the brain. And again, this is why I think it's been linked to ADHD and other impulse control disorders. Neurotransmitters, and again, this was talked a little bit yesterday, especially dopamine. And dopamine is kind of the neurotransmitter in your brain that is associated with kind of reward. Dopamine makes us do the things that we need to do for survival. So dopamine is why we like to eat, and we need to eat, and we get rewarded in our brains for things like eating. But the thought is that perhaps dopamine, in two subreceptors, dopamine 4, dopamine 2, the genes for these dopamine receptors are associated with binge eating disorder. The, again, opioid system. Also, there's some work linking the opioid system, and again, a system that is associated with normal liking of food, that it seems to be dysregulated in individuals with binge eating disorder. Certainly there's a genetic component. It runs in families. And not only does the behavior run in families, but these genetic differences in the neurobiology. So the brain's reward center, the dopamine genes, the opioid genes, those run in families as well. Clearly environmental influences also, and certainly life stressors. So again, if we talk about episodic binge eating episodes, that these are often triggered by stressful life events. Physical abuse, work stresses, all of these things can trigger an event that then can last for years, sometimes after the stress has been successfully managed. So in terms of management, starting the conversation with people, clearly general screening is important. Just, do you worry you've lost control over how much you eat? Would you say that food dominates your life? And I can tell you, interestingly, if you do that in a bariatric surgery population, some people will kind of go, oh my God, thank you for asking me that. No one's ever asked me that before. And that's exactly, that describes my relationship with food, and that gives you a real good opening to kind of start to screen more for binge eating disorder, for other people, and actually for most people. They'll kind of go, nope, that really doesn't kind of resonate with me because they don't have binge eating disorder. And for them, that doesn't characterize their eating. And so it can be really interesting to just start that. And then clearly going through things that are specific for the binge eating disorder diagnosis. There's a screening tool that's been developed. It's free online. Again, it is a screening tool, and so it's going to be overly sensitive. And so just because somebody seems to score positive on this does not mean that they have binge eating disorder, but it means that you can start to follow up and then probe around some of the questions. And so, again, if you're looking for resources, this is a good one to just help you sort of move forward. Some interesting work around the diagnosing this illness after bariatric surgery. You can't binge. It's physically impossible, especially kind of, immediately post-operatively, in the 1 year post-operatively, unless there is significant pathology. In the one case of kind of mortality post-bariatric surgery I was involved in, somebody who binged on pizza 24 hours post-operatively and died because they aspirated. And that individual would have had significant eating pathology, which in that circumstance had been diagnosed by all of the non-MD members of the team, but the person received surgery anyway. But if you're following up post-operatively for binge eating disorder, using the do you eat a huge amount of food in a short period of time is not going to be actually accurate because people can't do that. And so there are other scales that are better. There's a binge eating scale that talks about frequency of eating, and so it's, people whom are essentially taking a binge and spreading it out over the course of the day. That may be more sensitive if you're looking at things like eating disorder pathology post-bariatric surgery. In terms of, I am done. Other treatments clearly focus on body image, self-esteem, nutrition, psychotherapy, a number of psychotherapies, mindfulness, cognitive therapy, dialectical behavioral therapy. There's one medication that's approved right now. It's called lisdexamfetamine. It's used, or Vyvanse is the other name. It's actually approved for binge eating disorder, but it originally was used to treat ADHD, which is interesting. And there's some room for the use of antidepressants, primarily to treat other illnesses that may be associated with it. So if there's comorbid anxiety or depression, the antidepressants can be helpful. And so that was a lot of information in 15 minutes. Hopefully I can do one question.
Okay, perfect. Thank you so much, Dr. Taylor.
And I'll hang around afterwards if people have questions. Oh, Michael has sophisticated questions I can't answer, but I'll try.
Thank you very much, Val. I'd like to, there's a very interesting paper published just a few months ago. It comes from the Montreal Neurological Institute, and it's introducing the construct of uncontrolled eating as a unifying heritable trait that will help us to sort of organize this. And I'd just like to ask you if you could sort of clarify with us the importance in binge eating disorder of recognizing the psychopathology origins. And the reason is because I think it would be important to get your guidance as to how important are mental health interventions in the team with binge eating disorder, separating it out from other patients that would fall on this continuum of uncontrolled eating.
Okay. That is a whole other talk around the kind of psychopathology associated with weight, but absolutely, and again, I think it comes back to binge eating disorder rarely occurs in isolation. We talked about the sort of biological work, but that biological work, again, can be associated with other psychopathology. And then kind of to get to some of the things that Ian alluded to, there's often this cycle of eating pathology. People then become consumed with guilt and shame. That leads to lower mood. In an attempt to make your mood feel better, you go back to one of the things that is consistently available and that in the short period of time makes you feel good, which is eating, which when you engage in makes you feel bad afterwards, and that increases that kind of cycle of a vicious cycle of just guilt, shame, and eating, which continues to cycle, and then which extends itself to a whole host of other illnesses. And so I certainly think that, that really needs to be teased out from individuals whom have developed the illness of obesity for a variety of other illnesses, and the treatments need to be very, very different. I was part of a paper that was done on kids, and it was part of the group working at a sick kids, and it tried to look at different kind of types of eating that have resulted in children who are now experiencing obesity, and it's hedonic eating, so eating for kind of real pleasure, loss of control eating because of psychopathology, and sort of breaking things down. And it was quite interesting, sort of what they looked at, but no one's really done that in an adult population, sort of tried to really break it down to that level of detail, which would be interesting to do, and I think would be helpful for us in trying to make sure that we had the best fit. We also, the whole trauma and attachment style early on in your life, leading you to not feel like you have the proper supports. And again, food is something that's consistently available, and so then trying as an adult to rewire those attachment styles and to come up with another coping strategy aside from food can be very complicated as well, and again is what some people are struggling with, and emerges when they start to lose weight, and then some of these things come forward. And so I think that all of these things need to be kept in mind if you're an individual treating someone who has this illness, or if you're an individual who feels that they may be dealing with this illness. It's extraordinarily complicated, and don't feel that you should be able to do it on your own, and feel free to reach out. So thank you very much.
Thank you so much, Val. I actually have some questions that I want to ask you, but I'll save it for later. So with that, I'd like to introduce our next speaker. Dr. Sun is a professor at the Faculty of Medicine at Memorial University, and his research interest focuses on the genetic, nutritional, and endocrine factors of human obesity and diabetes. So with that, I'll let you take the mic.
Good morning. Yesterday I gave a talk, and we have performed some studies on food addiction from a point of nutrition, endocrinology, and genetics. Because by training I'm not a psychologist or psychiatrist. So, and yesterday, you guys treated me really kindly. It happened to me that I knew all the questions. So please continue. Yeah, food addiction is still, a big topic and largely in debate, because in the DSM-5, it hasn't been officially recognized as a clinical disorder. But it's at the early stage, and intensive research has been going on. And overeating, by gut feeling, it's probably it's an important factor to the development of human obesity. So chronic compulsive overeating, which characterized by an obsessive relationship to food. And here, and together with all of you, we're gonna, make some, a review and to look at the evidences, we obtained so far, how much, they support the concept of food addiction. So let's start from, the animal experiments. And the Rogers et al., they have a summary, or, a review paper, and that's published in 2017, and to compare the similarities between food and drugs. And as you can see, there's, a great similarities between the two. Yes, food, we need it. It seems that everybody loves food, and it's necessary to maintain our health and support our survival. But the key question is the proper amount. So between food and drug, and you can see, there's lots of similarities in terms of appetite comes with eating, and in drug, that's priming. And disinhibition of dietary restraint and abstinence violation effect in drug, and the food craving, that's a big, a concern, and drug craving, and tolerance to the physiologically disruptive effects of food ingestion, but similarly, in drug, so the tolerance is very, clear. You need more and more amount, and to reach the same effect. And side effects of acute food withdrawal. So in our food addiction study, we have observed and the patients reported, significant, a side effect. Food, the food you love to eat, and if they decided not to access it. And side effects of drug withdrawal, that's very apparent. And binging on food, that's a large amount. And just Dr. Taylor talked about it. And the binging on drugs, very similar to, between the two. And very classic, the paper by Dr. Avina, that's back in 2008. They looked at the sucrose solution at 10%. That's very similar to the, soft drinks we have daily. And give it in an intermittent way and plus chow. And they observe that, the rats, they're gonna, take in more and more the sucrose solution. And but they observed as well, with increase of intake of sucrose solution, but the intake of chow decreased. So in the end, the body weight of rats did not significantly increase. So we don't know yet whether it is a similar phenomenon, as happened in humans. And another study by Dr. Berner they look at the combination of sugar plus fat and the effect to total calorie intake. And they, give, the animals like 2 hours per day access to sweet and fat food. Or they give a different manner. That's a 2 hours access, but not every day. It's Monday, Wednesday, and Friday. And also, they have the standard chow and sweet fat only diet. And as you can see, the intermittent access to sweet combined with fat food, and the total calorie intake in both groups was significantly increased than the standard chow or sweet fat diet only. So this type of experiment just simply give us the hint that it's similar to the human diet situation. We have a lot of the fast food, the snacks, and super cheap available in the market that is often combined sugar and fat. And both of them combined together can change the way our brain respond to it. So we look at the animals, look at their body weight, and both groups, the 2 hours daily sweet and fat, and 2 hours Monday, Wednesday, and Friday sweet and fat, the weight increases significantly. And another, the study that was well known, publicly, and compared sugar versus cocaine. They use saccharin as sweetener. That's very often, they use in foods, in drinks, And they give, the rats a free access either, to saccharine or, to the cocaine. And after, a week or two, virtually all rats preferred saccharine over intravenous cocaine. So it's very surprising, and it indicates that the sweetener is a more highly addictive, drug than cocaine. So the addiction is involved in the neural, peptides and the metabolic way, and typically the master one is dopamine. Excessive sugar intake can sensitize dopamine 1 and mu1 receptors, much like some drugs of abuse. And opioid is another, the point that rats given an opioid receptor agonist and plus, feed them a sweetened shortening daily, and they ate significantly more standard chow. So it indicates that opioids, is also involved in food addiction. Chocolate, most people love chocolate, and it's a combination of fat and sugar, typically. Chocolate induced a persistent, conditioned place preference response. So that's an aspect usually associated with drug-related rewards in the animal experiments. And also a synaptic changes associated with facets of addictive behavior. And that's very interesting. So there's some other experiments available, but here it just summarizes. And food addiction, based on the accumulated evidence, is very similar to substance dependence and cause addiction-like behavior in animals, especially the one that the high sugar and fat combined together, and it shows typical tolerance, and it causes escalation of daily sugar intake. You need more and more to achieve the same satisfaction, and it has typical withdrawal symptoms, like in rats and the mice, and it causes teeth chattering, and forepaw tremor, head shakes, and aggressive behavior when you will withdraw the sugar from the drink, and it has caused the typical craving. 23% or more sugar after 2 weeks forced abstinence, and it has the increased basal level of cortisol. That's the indicator of stress. So in summary, it is very similar to what's seen in the use of cocaine or substance dependence. And now we summarize some of the evidence so far from human studies. And in early stage, in a good number of studies, compared and analyzed was the overlapping, like between binge eating disorder, just Dr. Taylor talked about, around 57%. In binge eating disorder patients, they met the criteria for the diagnosis of food addiction. And in obese patients, and they seeked weight loss. That's I need help. They talk to their, the family doctor or, their health center. 15.2% met the criteria for diagnosis of food addiction. 25% in obese patients not seeking weight loss met the criteria. And Dr. Gerhardt, in Yale University previously, and they studied the the female college students, and virtually 9% met the criteria. And our team look at the prevalence of food addiction in the general population. We are basically 1 in 20 adults, about 5% met the criteria of food addiction. And Dr. Davis in York University, they performed a study and to look at the food addiction symptoms, and they basically to look at the higher multi-locus genetic profile scores, and they found the MLGP scores associated with increased dopamine signaling. And the opioid expression levels, and this also increased, as we've seen in drug addiction. So there's some studies to look at, the brain changes, the brain imaging, and the things like that. And they use the functional magnetic resonance, and to look at some of the the area and a point, the frontal area, to look at the points when you show the cues of the food or chocolate shake, and the increasing signals or decreasing spots. It's very similar to the response when that you observed in the drug abuse. And another aspect, in food addiction, studies, they observed, many studies shows impaired control, and also, the impaired social engagement, like occupational, recreational, the engagement, and your patients you're gonna spend a lot of time rather than taking the food they like, and then attending those social engagement. And they also knew the risk to use the food, but they continue to use it. And in humans, we also observed tolerance and withdrawal symptoms. And there's a relapse, and there's the overall studies so it's all indicate. This is a study in the school kids. Is to look at the significant positive association between the uncontrolled eating subscale on the 3-factor eating questionnaire and symptoms of food addiction. But this is indirect study. So food craving, and another study by the Dr. Davis lab, they found out the significant food craving, and in food addiction, and they also they look at the self-identified chocolate addicts. They were subjectively aroused and reported experiencing greater craving when presented with chocolate-related cues. And this is, we want to repeat this, and they have reduced the social, the engagement. Another study shows, the greater tolerance, and also, the withdrawal symptoms. So it's the red light is on. I'm kind of nervous. Yeah, and there's a genetic study. That's a genome-wide association study, and they look at that. The WFAS scores significantly associated with the signalings in the mitogen-activated protein kinase pathway, and this pathway has been identified as a possible drug addiction pathway, but not in other addiction. I would say only in food addiction. And in our team, we performed a exome sequencing study as a screening stage, and then we verified the two candidate genes in another, the independent association study, that's a dopamine receptor 2 gene and the TRP gene. So, briefly, evidence from animals and humans predominantly support the validity of food addiction as a diagnostic construct, particularly as it relates to high palatable, processed food, high in refined ingredients, sugar, sweetener, and fats. Thank you.
Are there any questions?
Hi there. My name's Lauren Vogel. I'm here from the Canadian Medical Association Journal. Great presentation, and I enjoyed yours yesterday as well. I'm wondering if you could speak to some of the controversy around food addiction, because I know you referenced it briefly at the beginning of your presentation, and especially as people, I know certainly from covering some conferences around substance use, that there is a movement in addiction communities even away from the concept of addiction as stigmatizing. So could you speak to some of that controversy and how this relates to weight bias, stigma, when we're talking about addiction and food addicts? Thank you.
I think that's a good question, but it's a hard one to me though. Yeah, as a geneticist, from the genetic point of view, or the study findings from our team and the literature. Personally, I do think the food addiction is legitimate, but there's as I said, it is a great debate, and there's some negative findings as well in both animal experiments and in human studies. But in terms of the percentage, it's probably less than 10% of the studies they show negative or it's basically neutral results. Other than that, I would say we still need a lot of studies, a long way to go, and to convince the public and convince the experts in the field that food addiction is a legitimate clinical disorder. Hopefully, I answered your question.
Thank you, Dr. Singh.
Thank you.
Our next speaker is Dr. Sanjeev Sockalingam. He's an associate professor of psychiatry at the University of Toronto, the psychosocial director of the Toronto Western Hospital Bariatric Surgery Program at the University Health Network, and co-lead for the Extension for Community Healthcare Outcomes, ECHO, Ontario Mental Health at the Centres of Addiction and Mental Health and the University of Toronto. Please help me welcome Dr. Sockalingam to the podium. Thank you.
Thank you, David. So I realize I have 15 minutes, but maybe it's more like 5 minutes. So I'm going to try to go through this very quickly. Just for that question about food addiction, I will make a plug on a scoping review that we just recently conducted on the policy, stigma, and impact of food addiction in terms of broad-scale treatment. So just a plug, it was published in Nutrients just last month. And I think one of the things there it speaks about, and it's relevant to my talk as well, is that as we start to understand and evolve our paradigms for thinking about obesity and including mental health, just being cognizant of impacts on patients, access, labels, including psychiatric diagnoses and emerging diagnoses. And so just being sensitive to that and how we can pull in policy in a way to really advocate for our patients and our healthcare system are critical. So I'm going to make the case, and I do have some disclosures here. My main disclosure is I think mental health is critical to the care of individuals living with obesity, and that's my disclosure right off the bat. And I will try to do that by highlighting three things. So one, I was going to talk about and review some of the kind of comorbidities at a high level. Both Valerie and Dr. Soon ended up doing a great job highlighting some of that already, so I'll make some time up there, David, just for you. But I will focus more on evidence for psychosocial treatments. And I want to really focus on integrated approaches, and that last part will focus on some of the work we've been doing collaboratively with patients in our program and some of our research more intensively, and looking at providers and also our interface across delivery models as well. So this is my kind of usual slide, just to highlight, I think, the crux of this is that, as Valerie highlighted earlier, binge eating, as she alluded to, is not ubiquitous throughout anyone who's living with obesity, but there are high rates of overall psychiatric diagnoses in individuals living with obesity. And we know that in our sophisticated understanding as a psychiatrist and mental health providers that there are many pathways leading to mental illness, and there are many pathways leading to obesity, and many of those are shared, whether they be neurobiological, environmental, childhood adversity, and many others as well. And so we see mood disorders, anxiety disorders, and binge eating disorder being prominent, but obviously not in all patients, but things we need to be concerned about in our patient population. And we know with interventions that as we treat, for example, obesity, and here this is with bariatric surgery, and this is from the lab study, we see trends in how these things can improve, right? And overall, if we look at bariatric surgery, we know it's a durable treatment for severe obesity, and long-term studies with improvement in quality of life, improvement in employment and functioning. But we also see that usually in our trials, this kind of honeymoon phase after, and Ian alluded to this kind of adaptation afterwards and really trying to understand the impact on one's life. It also has an impact in addition to kind of psychosocial components, but biologically as well. And we do see that although the rates are improved overall with weight loss surgery in terms of psychiatric conditions, there is a reemergence as time proceeds after bariatric surgery again. And we see this kind of flattened U-shaped curve, albeit better than baseline, but still something that we need to intervene postoperatively. This is from the Look Ahead study, and just want to highlight, my slide is cut off a little bit, but I'll give you the crux of it here, that for the intense lifestyle intervention group, they looked at those who had no binge eating throughout the study, those who had new onset binge eating or during the course of the study, and those who had sustained binge eating throughout the course, they had at the beginning and at the end. And of course, those with sustained or new onset had worse weight loss outcomes in the study. So we see that if we don't treat mental health, it really curbs our interventions ranging from lifestyle, medication, and surgical interventions. And this is my kind of summary, and I joked about this at our kind of update course on Tuesday. This is almost like my career on one slide, and basically it is highlighting all the kind of factors in bariatric surgery that could emerge after surgery and that can impact patients and families. And we do see that there are things like relationship difficulties, a lot of press. I know Valerie and I have been asked to comment several times on divorce rates after bariatric surgery, and where the literature shows that there are pre-existing relationship difficulties that can be exacerbated afterwards, so really emphasizing a family approach. We know about body image and excess skin folds, the advocacy that's needed for plastic surgery and body contouring to address that, because we have good evidence that by doing that, we can further enhance quality of life for our patients. We do see, again, thinking about addiction, kind of this transference of addictive behaviors, and we also see that formal psychiatric conditions can either get worse after surgery or emerge as new onset. And there have been some associations, although albeit rare, with increased risk of suicide or self-harm after bariatric surgery. Again, quite rare, but higher than the general population. And again, something for us to think about, as there are probably multiple factors in these first two boxes and many others that are contributing to that, that could lead to better outcomes. And so just looking at kind of patient behaviors and what things might predispose someone to weight regain. Weight regain in bariatric surgery has gotten a lot of press in the last a couple of years actually, and there's actually a nice study from the labs that actually looked at what post-surgery behaviors and factors might be associated. I just want to highlight there are things that we've been hearing about, this loss of control over eating being one prominent kind of factor that probably spans many conditions. We heard about it in thinking about food addiction, but binge eating obviously being a core component as well. And we do also see things like sedentary time, but associated factors like venous edema, physical functioning, and depression. And you can see the associations between many of these factors and how they might contribute to worsening outcomes and kind of weight regain after bariatric surgery. And this is a study we did looking at binge eating disorder, binge eating symptoms, after bariatric surgery. And to Valerie's point, we see that as people progress, there's an increase over time, still better than baseline, but in binge eating symptoms. We also looked at emotional eating, but probably the most important finding here is that 1 year after surgery, after that honeymoon period, those people who had higher binge eating symptoms ended up having kind of lower percent weight loss at 2 years after bariatric surgery. And so, again, a significant finding for us because it shows us that 1 year is a really critical time to intervene and really engage with our patients. Probably we're engaging throughout, but making sure that we improve those outcomes early on. And then Labs 3 actually had a 7-year follow-up study of 184 patients, and you're seeing this common theme here that for weight loss, things that were associated with weight loss in a negative way is loss of control over eating after surgery. So really things before surgery didn't have an impact, but after surgery, loss of control and higher eating psychopathology after surgery were significant predictors. And I would say the good news here is they also looked at quality of life because we often get stuck on that weight and BMI component. And again, seeing that eating psychopathology was also a significant predictor of kind of worse quality of life, particularly in the mental health domain. We actually did a study in our Toronto Barrie Psych study that actually looked at 2-year outcomes, and mental quality of life is the toughest needle to kind of move in many of our kind of successful weight loss interventions. And so really speaks to thinking about expectations, but also what are the factors that we can intervene at to improve those other components of one's life. So I'm going to talk about evidence of psychosocial treatments in obesity, and I will start off by talking about kind of good assessment and that making sure we understand the complete domains: weight history, eating disorder symptoms, psychosocial history, health-related behaviors. And much of this is through the ASMBS as well. They have some nice guidelines about pre- and perioperative care. We've looked at this in a tool as well. I will say that we've used this tool to look at not as a gatekeeper of yes, no for bariatric surgery. This is an engagement tool amongst healthcare professionals to come up with a way of identifying domains that might need more specific focus or intervention. And so we think about those who seem to have supports in place, who have access care or don't have many comorbidities from a psychosocial perspective, those who might need more intense intervention, those who might not be ready for surgery right now, but we can start to intervene and highlight those domains where we need to bolster supports and treatments. I will say that those tools allow us to have that dialogue shared with our patients, and patient engagement is key, and also thinking about early intervention given what we know about the evidence about these early findings after weight loss interventions and how important mental health and treating mental health comorbidity is in patients who are coming forward for obesity treatments like bariatric surgery. And I will talk about more multimodal interventions. So this is, Valerie alluded to attachment style. It's one of the things we've looked at, and I will say it is the way in which we conceptualize through our early childhood experiences the world, including healthcare providers and how we engage with providers as a whole. A lot of literature in diabetes where avoidant attachment style is associated with higher 10-year mortality rates, so people dying from not accessing care for foot ulcers and other complications. In bariatric surgery, we often think about follow-up as being the key, and unfortunately, the the discourses have focused on, why aren't patients following up? But attachment style really focuses on the component that this is a relationship and that everyone has their own way of relating with individuals, and that as healthcare teams, we need to adapt to our patients in a way that we can engage based on their different experiences. And so using this scale, we showed that, we can predict who's more likely not to engage with the team in post-surgery aftercare, and how we could adapt with those one or two individuals on the team who did have a connection, and maybe trying to make those individuals kind of more the primary care leads or primary clinicians who are involved in engaging patients in post-operative care. Likewise, adherence to vitamins afterward, people who are highly anxious as well had associations with poor adherence, and likely that's related to some of the physical symptoms and sensations of taking vitamins and the myriad of vitamins after bariatric surgery. Oops, I'm going back here. And then I will say psychiatric medication use was work done by Valerie's group with the Ontario Bariatric Network that showed about 40% of patients were taking one psychiatric medication, and about 32% of those were on multiple psychiatric medications. So really looking at how, as a mental health provider, that we're not contributing to kind of weight gain and poor outcomes. And there are differences between antidepressants. This is maintenance treatment, not the acute phase, that there are differences in weight gain long-term with antidepressants. And so selecting agents that might be more specific and have less side effects is important. And I will say, Valerie talked about treatments of comorbidities. If we think about binge eating being a common one, lisdexamfetamine is approved for binge eating disorder, but this is an interesting network analysis, a meta-analysis that showed, and when you lump together second-generation antidepressants, that those medications have some benefit in many of the domains, like severity of binge eating days and compulsive eating, maybe not so much for abstinence of binge eating, where lisdexamfetamine is superior. So if you do have patients with comorbidities, antidepressants can be helpful for both the binge eating and mood components, and those with more severe, you may need to think about adding additional agents. And then this is about obesity medications. This is naltrexone bupropion. I think this is probably where new research is going to be emerging as we start to think about how obesity medications and how the brain is important to obesity care, that we see that we'll get some of these cross-treatment effects. And so this shows that in 25 women who had depression were overweight and obese, that there was reductions in binge eating with naltrexone and bupropion treatment. And again, naltrexone's been used in binge eating before, and so it's not a big surprise, but I think we'll see that as we look at liraglutide and other agents, that there may be other benefits from these agents in terms of some of the comorbidities. And then I'm going to focus on psychosocial treatments. Wow, 40 seconds. This is going to be fast. So there are some good evidence, and I won't belabor the point here, that as you get into more specific symptoms, CBT seems to edge out behavioral weight loss therapy, but behavioral weight loss therapy better for weight loss overall in the trials, especially in the short term, and more intense psychosocial interventions later. And I'll talk a bit about some of the new wave treatments. Mindfulness, there was a great workshop yesterday by people in the room here that looked at acceptance commitment therapy and mindfulness interventions, and this is from kind of Susan Winnock, who's wrote a chapter in one of our books and also done a study looking at feasibility of the mindfulness-based eating awareness treatment, and really can affect domains of kind of urges to eat, some of the stress-related and dysregulation, but also acceptance and tolerance of emotions that can influence eating. And I will say there is a nice meta-analysis as well, looking at interventions for patients who are obese and overweight, 15 studies, 7 RCTs. Acceptance commitment therapy actually had better long-term effects there. But you see that the biggest effects were in eating psychopathology, followed by depression, anxiety, and eating attitudes. The BMI kind of weight loss, the acceptance commitment therapy interventions had an edge as we start to look long-term. And interestingly, there's no difference if you give 12 hours or less versus more than 12 hours intervention. So there's like a sweet spot in terms of what's the actual dose of these interventions as well. So I encourage you to take a look at that. And then as I kind of go through the tail end here, psychosocial interventions pre and post-surgery. When I started, and many people in the room who've been working in the field for some time used to think about front-loading our patients with all the interventions. Both patients told us that that's not a good idea, and also our evidence showed us that it's not a good idea. That was really, there's an opportunity to educate and engage early on, but really focus post-operatively. And Melissa Kolarchin and Marsha Marcus had this and another editorial that really focused on the literature about increasing access, focusing on personalized approaches for patients, and taking step care approaches, and really focusing more post-surgery than pre-surgery, which is different than traditional models. And so here's my kind of access as we have technology. Many of you know that we have a telephone-based intervention that goes through 7 sessions, which has shown, again, in several trials that there's good effect sizes for binge eating, emotional eating. Interestingly, one of our students yesterday presented that those in rural settings had better responses, actually, which is probably because there's lack of resources, is our hypothesis in that setting, and improvements. And I will say, as we think about accessible interventions, Judson Brewer has looked at craving mind and mindfulness in that concept, and actually has patented an app which I have no licensing, or I don't get any credit for it, but you can get on the Apple Store, which actually is a mindfulness-based intervention. And they had a 28-day self-paced mindfulness app where they released different modules at certain time intervals, so you couldn't binge watch like on Netflix on the app. And they had 5 to 10 minute videos, and actually showed a pretty good completion rate of 75%, and had reductions in craving-related eating, self-repeated overeating, and weight loss in timely completers. And that was at 4 months kind of post-intervention. And then here's another intervention, just to say that although intense CBT, 20 hours of CBT, is excellent and better than self-guided with 2 visits, one at the beginning and end, actually still came up with abstinence in close to about 40% of patients when you look at long-term follow-up. So, it really states that if we don't have much to offer, if we can't do intense CBT, even self-guided with a little bit of support can still have significant impact for many patients who can't get access to treatment. All right, so I'm just reiterating a stepped care approach, and I want to just end here that mental health specialists are important, and we had a paper that really focused on the role of psychiatrists, but you can substitute mental health specialists in bariatric surgery care. And I will say where we need to move, this is my last 2 points here, that in more integrated models, and there's great evidence in other chronic diseases, we've been talking a lot about obesity as a chronic disease, and that there are collaborative care models that are evidence-based with key components, but if we start to implement those components of collaboration, evidence-based treatments, measurement-based care, really bringing together behavioral care managers, and those could be social workers, but in bariatrics, I imagine in our programs, it's dietitians, nurses, et cetera, bringing that together with primary care providers and the specialists, and with psychiatric or psychology consultation, that we can improve outcomes. In depression, when these models were introduced, we had a 50% or greater improvement. They're used for better diabetes care, cardiovascular care as well. And so in order to do that, we need to build capacity, and I'm just going to plug there's Project ECHO, and many of you may or may not know about that, but Project ECHO is a televideo conferencing evidence-based treatment, clear model, which is like 300 sites across the world, that really has expanded how to treat chronic complex diseases, and I would argue obesity is one. The Ontario Bariatric Network and Sick Kids in Canada have really kind of focused on this. And we've looked at some evidence, and it's actually one of the few, because it is such a systematic model that has key components, and you get trained on this model, that there have been studies in dementia, diabetes, and hepatitis C that have improved patient outcomes and cure rates. So hemoglobin A1C, better on ECHO than without ECHO. Hep C, better cure rates, and treating people closer to their homes. It is a televideo conferencing one-to-many. We usually get about, in our mental health ones, 30 sites simultaneously at primary care sites, working together and providing evidence-based care. So another thing to keep in mind, and that's the website. And so just bringing it full circle to Ian's point here, one of my graduate students who has a poster out here has been working on patient-centered approaches and integrated care models, including in bariatric surgery, and this came from patients and was actually with a study done with a patient an investigator, and thinking about our patients wanting providers to collaborate with us to build that alliance, personalizing care to our needs here, and really supporting and helping self-management. And again, thinking about how we can do that through advocacy and these new models of care is critical. And I just have a quote from one of the participants in our study, one of the patients, that really it's about that holistic model of care that integrates kind of behavioral mental health and really thinking about someone who understands the individual advocating on part of their team and the system and working together to really address stigma and impact. So hopefully, Ian, I brought it full circle to echo some of your early points and expertise. All right, I will end there. Okay. Oops.
Hi, any questions?
No questions. No questions, sorry. I was over my time. My apologies.
I'd like to thank Obesity Canada for bringing this high caliber group of speakers to us today. Thanks to the speakers for their very informative sessions, and thank you for everyone for attending. Thank you.